O tira te whare e tū nei ko awatea, tēnā koe. E tū. E tū tonu hei manaki mō te iwi. Hei kai whakaruru hau mō te iwi. Hei whare wānanga. Hei whare hauora. O tira ko awatea, ko tēnei hoki te rā tō rā. O tira te mihi atu ki a koe te kai whakahaere, tēnā koe. E kōrero mai ki a tātou katoa, i roto i ngā mea no iho. O tira ngā reo, ngā karangatanga maha koutou o te kāinga, tēnā tātou katoa. Thank you, Bernard, for the introduction. And thank you also for extending the boundary of rangitane. We always knew that was the case, but we've had trouble proving it. Now we've got an authority who can affirm it. And thank you for thank you for not mentioning that Te Āti didn't always beat St. Stephen's, but quite often. And thank you for the invitation to be here at the symposium. Really wanted to be here at the opening of Ko Awatea because I think it's a wonderful innovation. Brings together different groups of people. It brings together different institutions. It brings together different sectors, and that to me is an amazing development and a great prescription for the future of health into the future. Now, any of you over the age of 50, one or two. You all know as well as I that when you get over the age of 50 or sometimes 35, that you get better and better at remembering things that happened a long time ago. And that's what I want to talk about, what's been happening in the last 25 years to mental health and mental health care and the contribution that Māori have made to that process. And then, if there's enough time, and that'll depend on Bernard's generosity, if he's generous in the boundaries, I wonder if we're generous with time. If there's enough time, talk a little bit about where we might be looking towards in mental health in the next 25 years. So that's basically what I want to do. And really the starting point is that in the last quarter century, last 25 years, mental health in New Zealand has been transformed in a way that none of us could predict in 1980 or in the late 1970s. It has changed in a dramatic way. What we do today in mental health, we tend to take for granted. It was not always like that. And Māori have had quite a large part in reshaping the whole direction that mental health care should take in this country, if not in other countries. And there are four pathways that have contributed to the shaping. The first one was to think about what do we mean by health, and so to lay down a concept of health that might be useful for thinking not only about mental health but health generally. The second pathway had to do with what I've called the indigenisation of mental health services, introducing a Māori perspective and a Māori way of doing things into the health services that we had at the time. The third pathway was the development of independent Māori providers who were able to use culture as a strong basis for the development and the delivery of their services. And then the fourth pathway has been a hugely significant one, which has been the development of a workforce that we didn't have 25 years ago, nor ever dreamed about 25 years ago. So that's they're the four pathways I think that have contributed to the transformation. The first one had to do with perspectives of health, and we know now that people from different cultures view health in different ways, or maybe not entirely different, so they emphasise different aspects of health. And about 1983, this idea was being put out that there was a Māori perspective in health, a Māori way of doing things. It was important for a number of reasons. Probably the most important reason was that although the World Health definition of health was a good one, not everyone felt they could own it. And in New Zealand in the early 1980s, health was owned by the health professions. It was not something that consumers owned. It wasn't something that families owned. It was owned by the health profession. A Maori health perspective made it possible for Maori to think that health really was theirs. It didn't actually belong to the health profession. It didn't actually belong to hospitals. It belonged to them. And so that was being able to frame health in a way that made sense to people. And some of you may have heard of whare tapa whā. This is one example of a health perspective, a very simple one, although it can go into quite a lot of depth, and if you want a reference and want to know a good book to buy, I could tell you afterwards. But what it basically said, that health is a balance, and it's a balance between spirituality, it's a balance between mental, emotional and intellectual dimensions, physical dimensions, and a social dimension in the way of the family. So that was a fairly simple definition. It appealed to Maori. It appealed to the Maori Women's Welfare League, who in 1984 took a major study of the health of Maori women, and the tool they used, the framework they used to analyse their data was essentially the framework of the whare tapa whā. So their argument was that the health of Maori women, you've got to think about their spiritual health if you're going to get an overall picture of what their health might look like. Spirituality was a bit of a problem for my medical colleagues. They've gradually warmed to it. Their first vision was that they'd have to go to church, but that of course was a narrow view of what spirituality might entail. But the development of a Maori perspective on health began to lay some foundations to enable Maori people to feel that health was theirs, that they could own it, and that they could aspire to take responsibility for it. And that was a new sort of message. The other point about a Maori perspective was that it introduced the notion that Maori knowledge, Indigenous knowledge, has a validity of its own. It's different from science, and it doesn't mean to say that one is right and one is wrong. It's just that we've got two different pathways of knowledge. And the really interesting point was that most people actually live somewhere in the middle. And the interface between Indigenous knowledge on the one hand and science on the other, which is the foundation for health as we know it today, that in there's an interface, and that since most Maori people live their lives in both worlds, that having being able to draw on two models of health was important to them. They're not all the same. They come from different angles. The angle that I think is most appealing is that in Maori knowledge, the older you get, the wiser you get. For the medical profession these days, generally, the older you get, the more out of date you become. So I'm very attracted to the Maori version of what age can do for you. But the other thing, and this is quite a difference in my way of thinking, the knowledge that withstands time enhances in value. We know that in medicine there is a rapid change in the knowledge base, and we tend to value new knowledge, and that's what research is about. It's about new knowledge, generating new knowledge. We tend to value new knowledge. So there's a different way of looking at the world. They're not antithetical, they're not opposed. The challenge, I think, for all of us is how to use those two constructively and in balance. So this was another aspect that came out when talking about a Maori perspective. We also had to look at the idea, the relationship of one set of knowledge, one system of knowledge, Indigenous knowledge, and its relationship to the whole world of science. There you are. There's the interface where a great deal of debate occurs. I imagine that there will be quite a lot of debate in Ko Awatea about that interface, and I believe some of that interface was seen at the opening of this building, which means this sort of message is embedded in the building and what it stands for. The next pathway, a really important one, was the idea that Maori values and Maori ways of doing things might be migrated into the hallowed walls of medicine and into hospitals. Again, a new idea that there was only one sort of health prior to the 1980s, and that applied to everybody. But the breakthrough probably came at a unit at Tokanui Hospital called Whaiora. Tokanui Hospital was a large psychiatric hospital, 1,500 or 1,600 beds, located in a rural area, which was the fashion for mental hospitals. And prior to the 1970s, the number of Maori patients there was actually quite small. It was less than you would expect. From about 1970, mid-1970s, that changed, and you tended to get many more Maori patients coming in. There were a group of Maori nurses who were working at the hospital, and they felt that the milieu of the hospital culture, was not helpful to the recovery of Maori patients, and they thought there might be another way of doing it. And they persuaded the hospital authorities, the superintendent at the time was Dr. Henry Rongamo Bennett, who didn't need that much persuading, that they might set aside one villa where you would have Maori values and Maori processes applied, and they called that villa Whaiora. And it introduced a new way of doing things in what was a large, unchanging, conventional mental hospital. Patients were not confined to the hospital, they were openly welcomed to the hospital. Quite a different approach to why you're there. People were not alienated from their families. The families were encouraged to join them and to stay with them until they felt comfortable about being there. The doctor was not God. There was another god. They had to pray to him, so they introduced karakia into the routine of the hospital, which was fairly unusual in those days. The doctor was not the only authority. Kaumātua were employed, elders came in, and they were on the staff of Whaiora to offer advice, support, wisdom. So this was quite a different approach to the management and treatment of people who had mental illness. Largacta was still prescribed. Haloperidol was still used in large quantities, but it was used, there was a different culture established alongside it. So it was quite a good example of bringing two approaches together, science and the ideas we had then about psychotropic medication on the one hand, and a value system that valued people and valued their culture and valued their perspectives. So that was the first real introduction of Maori values into a hospital, and it occurred just down the road from here and just at Tawamutu. There was another one that occurred much closer to here, the second one, at Carrington Hospital. That was another Maori health unit which was developed. That had a different approach. That introduced Maori values, but it decided that they did not work well with science and health science and psychiatric medicine. And so the doors were locked and no doctors were allowed in. And it was a run with Maori values entirely. There was quite a lot of discussion because the superintendent knocked on the door several times to see if he might come in to do his ward round, and said no, he's not required today, which didn't go down that well. So that didn't end well. It ended badly in court. But the difference was that in the first effort at Tokanui Hospital, the people who initiated it were standing in two worlds. They were nurses, they knew about psychiatric care conventional, they were Maori, they knew about the Maori world, they were able to bring them together without any sense of disjunction or conflict between them. The Carrington Hospital approach used one model which flew in the face of the other model. So a bit of experimenting went on, useful, but now, of course, in hospitals generally, but especially in mental health services, the ability to weave together two strands of thought and two ways of doing things is no longer novel. It's become the accepted practice. It wasn't always that way. The third pathway was, and this developed in 1993 after health reforms, was the ability for Maori organisations to have their own health service. The first one was started in 1984, and that was Raukura Tainui Hauora Tainui Raukura Hauora. That was the first one. Still going strong, but it was a struggle, and many people thought that this was a bad way to go, that people would get second-rate type of treatment. They had trouble funding it. It wasn't until the health reforms of 1993 when the funder and provider arms were split, and the notion of contestability was introduced into health services so that other groups than conventional health providers could also tender to provide a service. And that's where Maori health providers developed. Basically, Maori health providers have a conventional approach, and that's what the methods they use are not radically different from any other provider. What is different is the way that it's delivered, so that there's a different approach to delivering a service. Maori health programs that are treating people with diabetes don't abandon medication, but the way that they get compliance from patients, the way they encourage changes in diet depends much, much more on the interaction and the engagement they can achieve, and very often that engagement is enhanced by the fact that they don't have to explain a cultural difference. That's really important. If we belong to one culture, we understand that culture intuitively. We never have to think about it. If you're with someone with another culture and you don't think about it, you're likely to have some difficulties engaging in a meaningful way. I'm told that overseas doctors who come to New Zealand have some difficulty not understanding Maori patients, because quite a lot of overseas doctors are used to working in multicultural situations, much more than most of us in New Zealand are. The problem they have is understanding the average Kiwi bloke. And, well, the average Kiwi bloke, who's becoming a bit of a dying breed now with all these new age men on the scene, but the average Kiwi bloke sits in a doctor's surgery, and the doctor says to him, "What's wrong?" And he'll say, "Well, nothing really." And then he'll say, "Are you hurting much?" And he says, "No, not much." Now, if you don't know the average, the way Kiwi men think, you would think this guy is wasting my time. But if you understand the Kiwi mentality, you're attuned to the Kiwi psyche, and you know the Kiwi culture, you say, this man is seriously ill, if only by the fact that he's here. However, New Age men have no trouble saying exactly how much it hurts and how bad life is. So independent Maori health services then was an important development in this way of transforming. Quite a lot of the independent services focused on mental health, either in the rehabilitation end or in providing an ancillary service to what was offered from mainstream providers. Fourth pathway was developing a Maori workforce. The Maori health workforce was small, and it was focused on one or two areas. There was a conscious effort made in the 1980s to expand that, and to expand it in a number of directions by getting more people into the professions, the established professions. That's been quite a successful move. By extending the workforce to include other people that were not normally regarded as part of the workforce. Cultural advisors, kaumātua, liaison workers, elders, consumers, seeing them as part of the workforce and in making a health system that could incorporate them and use the skills that they had that other people didn't have. And that was important. Then the other workforce was really helping the workforce generally to become more attuned with other ways of looking at the world and with delivering services. And then more recently, been quite a concentrated effort to build some expertise in governance and management, which is a critical part of healthcare and health systems.